The broadcast is now starting. All attendees are in listen-only mode.
Ladies and gentlemen, welcome to today's webinar titled Coding and Billing Updates for Physician Assistant Services, brought to you by Webinar Planet. This webinar will be presented by our industry expert, Jill Young. It will be recorded to purchase later in a form of DVD, flash drive, transcript, and digital download. If you wish to ask any question during the webinar, kindly type them in a question box and it will be answered by a speaker during the question and answer session. Jill, welcome to the program. We are now ready to begin.
Thank you so much, and good day to everyone. I apologize for my very squeaky voice. Those of you that may have heard my voice before know this is not normal for me, but look at it this way, you won't have the tired old Jill voice. You get something new to listen to. When we're talking about coding and billing for physician assistants in 2024, there are some new things, but we also continually have to be reminded of the old things, if you will. Things like state scope of practice, that every state defines exactly what it is that the provider as a physician assistant can do in caring for their patients. And it defines that and is referred to in all of the manuals that you look at. So first and foremost, you have to remember, just because they can do it doesn't mean they should do it. Their state scope of license needs to be validated to find out what can they do independently, etc. And understand that it can have some significant changes state to state. And so you always want to know, for the state that you're in, what is appropriate when it comes to services for our physician assistants. There's a website called Scope of Practice Policy, and it talks about supervision requirements. And many times there's a need for this collaborative agreement that outlines exactly how it is that the PA is going to perform their duties within that practice. What is the supervising physician's role for them, and what kind of interaction do they have? For example, I live in Michigan. Michigan used to have a rule that said that they needed to meet on regularly scheduled basis to go over patients. So that didn't mean, when they needed to. That meant that they were supposed to be regularly scheduled. And theoretically, someone should have written down those dates and had notes of, what sort of in a general sense they did meet what was discussed. So again, we look to the state medical board and also look at the practice level to see what is it that they can do. So as I said, I'm from Michigan. It says in our Michigan law that the practice is a subfield in rendering healthcare. PA cannot delegate task or supervise. And that's our first big thing to remember. Do you have that type of restriction in your state that says that they cannot be the supervising entity for residents or for other PA students or anything like that? What's in their state scope? So for Michigan, they can't, but that doesn't mean in Iowa or Indiana that maybe they couldn't. We've had some changes to our PA rules in the state of Michigan, and when we look at that, and there were some changes at the national level as well, but we now have in our rules, it says that there is a practice agreement in place that's sort of defining what's going to happen, their availability, what's the protocol in looking at designating someone if that doctor's out of town. There was previously restrictions on the number of physician assistants that a doctor could supervise. That is no longer there. So, there's always changes, and so you want to make sure you're aware. So when we look at some of the changes that happened to PA services back in 2020, they wanted to allow for all of our non-physician practitioners to be able to be the supervising provider when it came to certain diagnostic tests. Previously, very specifically, the rule said that only physicians could supervise tests. So if you looked at cardiac stress test that required the physician to be in the department, a PA could not be that supervising entity. They weren't allowed. Now, again, that changed in 2020 and allowed them to meet that supervisory role. Now, as the supervising entity, that now means that it needs to be billed under them. So allowing them to bill directly to Medicare and anyone who follows Medicare rules was kind of a big deal. As we look at different states, and this is, I gave you the website, hopefully you can easily copy and paste it to get this PDF that has a lot of information about exactly what is the, as they're calling it, collaboration requirements and barriers. You can see we have it by state. What do we need? Do we need a co-signature or not? Prescriptive authority. What is the language? Is it supervisory or is it collaborative? You know, so giving those pieces of information, you can see in Alaska, now Alaska certainly has some rural to it. Collaborative plans must include at least monthly telephone, radio, electronic, or direct personal contact between the PA and primary, reviewing the PA's performance in the practice. So regularly scheduled meetings, if you will. So that is one of the rules if you're in Alaska. If we look at another state, we can look at Maryland, where it says requires continuous physician supervision mechanisms that are reasonable and appropriate to the practice. The physician is expected to respond in a timely manner when contacted the PA. So giving information, also in Maryland, you'll see the physician cannot delegate to more than 4 PAs at a time. So the rules can be different state to state. And then there was Michigan. So when we look at our CMS or Medicare rules, there is a document that came out, and this was from the Internet Only Manual, and I like to give you references so you can go find them yourself and look at them. So there's that reference. There's also this from March of 2022. And then there's also the website page that has information about all of our non-physician practitioners. And looking down specifically, there's a tab for PAs. And then within that tab for PAs, there's all kinds of information as we look at it. Probably the biggest is we look at is the coverage and documentation guidance. And so the first thing it says is we cover services according to state law and scope of practice. And remember, what that means is even though they might be able to provide a service, they might be able to see a patient independently, if their state scope of practice doesn't allow them to do that, they're out of the bounds of their license and therefore would be practicing inappropriately. And that's a significant problem and has legal ramifications. So it says, we cover services when furnished according to that state scope. You can provide an assisted surgery. Auxiliary personnel may have the services and supplies provided incident to your own professional service. And what that means is if you're, for example, seeing a patient in the office and you want the MA to give a shot to a patient, you are directing them to do that. It is an incident to service, incident to the PA's billing for that day. We have billing guidelines, and it talks about they will pay directly for NPs and our clinical nurse specialists, and they're going to pay like that. Remembering there was a change somewhat recently. It used to be that PAs could not form a group, and although they had to officially work for a group, they couldn't form a group of just all PAs. Now they have much more flexibility in the formation of exactly what it is that they're wanting to do to set up their practice model. For payment guidelines, only on an assignment basis for PAs and most of the non-physician practitioners, and you can't charge a patient more than the amount permitted under the fee schedule. We have references to our Medicare Benefit Policy Manual and our Medicare Claims Processing Manual for information. So what exactly is an incident to service? And we're going to talk about Medicare rules here. And this is for anyone that follows Medicare rules not just Medicare, but follows Medicare rules for Incident to services. We are also talking about our Medicare Advantage plan patients. And this can create some discourse in that XYZ commercial insurance may allow certain things, but XYZ Advantage or our Medicare product has to follow Medicare rules and may not be able to follow that. Remember that a Medicare Advantage plan can give you more benefits than you would have under Medicare, but not less. So if we look at our benefit policy manual, it says that when we look at incident to services, we don't have to have the physician seeing the patient every time or every other time, if you will, in order to meet these guidelines. But it does say that there has to have been a direct personal professional service furnished to initiate the course of treatment for which the service being performed is an incidental part. I want to be sure we take a moment to talk about incidental service. Incidental, though integral, is the words that we hear. And those are the same words we hear for our ancillary or auxiliary services to patients. So we're going to come back to that in a minute, but just remember, incidental service is what incident to is defined as. The rules then say that there has to be subsequent services that show that the doctor is involved in the active participation and management in the course of the treatment of that patient. I know when I first started working with this, there were a lot of practices that would say, well, the doctor has to see the patient the first time, but then the NP or PA can see the patient for all time on their own and bill it incident to. And that's not correct. There has to be certain things in place, including interaction with the provider, showing that they are actively involved in the management of that patient. Now, each of our Medicare administrative contractors, our MACs, have to follow CMS Medicare policies. They may have additional information on their website. Some don't, some do. Some will have documents you can download, some won't. And so you really need to go to your MAC's website and do a search for incident to and direct billing and non-physician practitioner services and see what you can find. When we look at my MAC, which is WPS, it reminds us that incident to doesn't apply to services that have their own payment category. So you say payment category, what does that mean? Well, they tell us clinical lab services have their own payment category, so you would not have to follow incident to there. And those other items that are listed, all of which have their own payment categories, so it does not apply, meaning you can't have a service where the physician has directed, if you will, the PA to do something and they're going to bill it under the provider's number, even though the PA is doing the work, so to speak. CGS also has a fact sheet on their incident to, and it talks about incident to is not applicable for some services. It applies only to services that don't have their own benefit category. Oh, we heard that before. Benefit categories are defined. The following services have their own benefit category and specific levels of supervision. Notice this list has more services on it than the previous list did. Different carrier, different list. Noridian is another carrier, another MAC. Their website has incident to services. And then they talk about billing, where we have services incident to should be billed under the employing physician's NPI. The following practitioners must accept assignment. Incident to billing is paid at 100% of the physician fee schedule. If the service doesn't meet the incident to criteria but qualifies for practitioner payment, it's made at 85%. So they're laying things out, spelling things out for you in different levels. So again, notice the lists were different for what their own billing categories meant, but that's just why we have to pay attention. So CMS's criteria for an incident to services, this is as identified from WPS, my Medicare carrier, my MAC, that there has to be a professional service. It has to be performed in a non-institutional setting. What does that mean? It can't be in a facility setting. So if your practice location is outpatient department of the hospital, and those are the situations where your patients are getting 2 bills, then those you're not allowed to bill incident 2 if you're a facility biller. The place of service changes what the rules are for PA services. There has to be an employment status. In other words, everybody has to work for the same tax ID. So you cannot have your PA moonlighting on the weekends for another practice and doing appropriately documented incident to work and have the other practice bill for services unless there's an employment relationship. Now, for weekend coverage, that would be very simple to institute a contract, but they cannot work incident to someone that they do not have a working relationship with. And there's that services have to be incidental again. And then there is a level of supervision required. Now, my MAC carrier talks about, and this is a talk that was done just a couple months ago. It talks about the PA services for ENMs. They can report the level of service based on the documentation, and we have other professional services that they may be able to bill for. And again, when we talk about a non-institutional setting, and I sort of narrowed it down to physician office working in a facility, this is my reminder to talk about a nursing facility doesn't meet that. And so making sure that that place of service isn't making invalid the methodology you're looking at to bill. So the billing provider decides on a diagnosis, they do the medical decision making, and they lay out a plan of care. The rendering provider follows the plan of care, and any change in that plan of care no longer means incident to guidelines. The billing provider continues to follow the patient to meet that active participation and to manage the patient's diagnoses. But I want you to pay attention to, and let me get my little laser pointer here. A change in the plan of care no longer meets incident to guidelines. What does that mean? Well, if the patient comes in and they're being followed according to a plan of care that the physician set for, say, their hypertension, and they come in and their blood pressure is through the roof and the PA is going to order tests, order labs, something's going on, that's out of the plan of care. Incidental, though integral, means the patient is stable. Incidental, though integral. I always think of incident 2 as the example I used before with telling the MA to give a shot to a patient. So let's think about that for a minute. If the doctor told the PA to give a shot to the patient of, let's say, 40 milligrams of Depo, and the MA went into the room and heard the patient's voice was like mine, and they're like, wow, she's really sick, I'm going to give her 80 of Depo. Well, the nurse MA can't make that decision. They can't change the plan of care. Well, neither can a PA when providing an incident to service. They can't change medication. They can't order tests and still have it be incident 2. The minute that patient had a problem, had a change, had a new problem, they were out of the bounds of incident 2. And now the decision has to be made. Is the PA going to continue providing services to that patient, or is the doctor going to step in and take care of the patient? So have to be very careful when there's a problem, if we're following Medicare rules, that the minute there's a problem, you're out of the bounds of incident 2. Now, Novitas, another MAC, says services must be part of the patient's normal course of treatment, during which a physician personally performs an initial service and remains actively involved in the ongoing course of treatment. Okay, that makes perfect sense. And then next it says billing incident 2 The physician has to initiate treatment and see the patient at a frequency that reflects their active participation. This includes both new patients and established patients being seen for new problems. And those claims should be billed under the physician's NPI, and they are providing the service, making sure that we're not billing them inappropriately incident to. Novitas goes a little further and says documentation must clearly indicate the physician's presence in the office at the time of the service. That's a little more than I've seen from some of the other carriers. And then it also says services are within the scope of the NPP as defined by state law. So Novitas takes it a little bit further when they're talking about incident to services. They're saying the documentation has to support, clearly link the services to the services of the supervising physician. Evidence of the link can be by a co-signature, documentation from the other dates, in essence, referencing back and saying, you know, I'm seeing this patient under the, excuse me, plan of care from January 21st that the doctor put in place. Pardon me. CGS talks about incident to scenarios. Oh, goodness, excuse me. My apologies. The document should be signed by the supervising physician. We don't see that again with all carriers, just some. Palmetto has information regarding split shared visits in addition to incident 2 that we can look at. And there are different versions of this that we can look at. National Government Services has this quick reference chart. And so you need to go to your MAC to see what is the latest and greatest, remembering that the CPT rules, the AMA rules for office and other outpatient services changed in 2021. And then the rest of the E&M rules for selecting level of service changed in 2023. And so some of that ties into the services of our PAs. So we want to make sure we're seeing the most up-to-date guidelines from our MACs. So again, this link between the services where we have the location and the date of this plan of care that they're following. In other words, if I'm an auditor and I'm looking at a note today that's by a PA that says that Jill came in for her hypertension, which is stable, and it's billed under the doctor, I'm going to go, well, why is that? Well, if there's a note in the record that says I'm seeing the patient under the plan of care written by Dr. Smith on January 1st, then now I know where to go to see exactly what is the PA following for instructions, if you will. CMS tells us that the progress note has to substantiate the level of service, and that reminding us that if the physician is involved in a particular service, and I'm not talking about split shared, I'm talking about the PA comes out of the room and talks to the doc about the patient, and the doc gives them advice or something, goes on their separate ways, the PA goes back and finishes the visit with the patient. The physician should document that interaction because it does show their continued involvement in the patient's care. And so having that documentation can meet that requirement for ongoing care. Novitas tells us that initial history and physical performed by a non-physician practitioner, although the physician may be documented as being present or in the office suite, it's not covered under our incident to guidelines. Any initial service has to be performed because how can our PA follow a plan of care if the patient's not ever been seen? Novitas also tells us that they're going to deny claims or downcode claims billed as incident to when an NPP performs that initial H&P. So integral though incidental. That's the buzzwords that we look at. So incident 2 doesn't apply in the hospital setting. It has to be an expense to the physician. It requires supervision. Normal incident 2 requires the doctor to be in the suite. Can't be for new patients. It can't be diagnosing and treating new problems. We're following a plan of care that was initiated by the physician, and the physician is actively involved. Now, there's no signature required by the physician according to CMS, but we have to look at your state law and your MAC to see if they require a physician. And then we also have to, when we think about an incident 2 service in a group setting, supervision for the day may be by a physician other than the one that wrote the plan of care. And we need to reflect everybody's name appropriately on the claim form. So I refer to the big S and the little s supervision. The big S being the big supervisor, perhaps on their contract, and then the little s being that level of supervision in order to meet incident 2. If we think about, I come in to see the PA and Dr. Smith is the one that wrote the plan of care, but Dr. Jones is a member of the group and he is in the office today, we have to reflect both of those physicians' names on the claim form. And I have that information a little bit later, but we have to make sure we reflect both of them. Our supervision during the public health emergency may have had some significant changes. It allowed for the direct supervision to be provided using real-time interactive audio and video technology. And CMS said, we know that, there are some risks of exposure during the PHE. And so it's like, let's just back off that in-person requirement so that we can move forward. So during the public health emergency, CMS changed that definition of direct supervision to allow for that virtual supervision where we're using real-time audio video technology, and that this temporary exception allowing for this appropriate billing of incident 2 services, this flexibility, if you will expire at the end of 2024. Direct billing is pretty straightforward. The non-physician practitioner, PA, bills under their own billing numbers. It allows for them to get paid for services directly. They have to be credentialed specifically. So seeing new patients, new problems is not a problem. Now, I've mentioned the changes that we saw in 2021 to outpatient office and other outpatient services, and then the changes in 2023 to all the rest of the E&M services. One of the things that we saw in this original document was working with the definition of split shared. We know that previously CMS had said that they were trying to make some adoption of what rules they were going to follow. CMS in 2021 said that they were okay with the office and other outpatient services rules, with the exception of some of the split shared things. In 2022, they said, okay, this definition that has come out of those changes to the E&M about what a substantive portion is, we're defining it as someone who either spends more than half the total time or the provider that performs the history exam or medical decision-making, one of those three in their entirety. That would qualify as a substantive. And that was the rule in 2022. In 2023, that was the rule. And that was the proposed rule for 2024. They were going to once again make that exception, allowing for the practitioner that performed all of the history, all of the exam, or all of the medical decision making. But then in the physician fee schedule final rule for 2024, they said, well, CPT has made some significant changes. So for the purposes of Medicare billing, the definition of substantive means more than half the time or a substantive portion of the medical decision making as defined by CPT. CPT is looking at defining split shared visits, talking about our physician and other qualified healthcare professionals working as a team. And it says the guidelines are applied to determine which professional can report the service, defining first, if looking at time, that it's the substantive portion. If the code is based on the total time on the date of the encounter, the service is reported by the provider who spends the majority of time with the performing the service. That does not mean with the patient, it means performing the service in an overall nature. And then it says in the purpose of reporting within the context of team-based care, performance of a substantive part requires that the physician or other qualified healthcare professional made or approve the management plan for the number and complexity of problems, which is column 1 in our elements of medical decision making, and takes responsibility for that plan with its inherent risk of complications and or morbidity or mortality of patient management. That's the last column. And it says by doing so, whoever has performed 2 out of 3 of these elements used in the selection of code level based on MDM allows for that selection of which value. But then it goes further, and this is from the 2024 CPT book. It goes further and says, if the amount or complexity of data to be reviewed is analyzed to determine that code level, then addressing an independent historian's narrative and the order or review of tests or documents don't have to be personally performed by the physician or other qualified healthcare professional that is billing the service, because those items would be considered in formulating the management plan. Independent interpretation of tests and discussion of management plan or test interpretation, those are the items from the elements of medical decision-making grid that have to be personally performed by who is ever billing for the service. So if we look at a plain language version of what are they saying? Well, first of all, definition 1, we've got based on total time. On the date of service, there's specific activities listed. The provider that performs the majority, that spends the majority of time with the patient, that spends the majority of time in the care of the patient, both face-to-face and non-face-to-face, that allows for the reporting of time and who performs the substantive part. For the second definition, we have to have a provider that meets both the requirements of approving the management plan and also taking responsibility for the plan. And so the provider who meets both of those requirements is the one that would be the billing entity. And then number 3 says, if the amount and complexity of data reviewed, that middle column, is to be used in selecting the level, so as one of the 2 out of 3 elements, then the relevant elements must be personally performed by the billing provider. So not by the PA. So it just depends how the service comes out, exactly who is supposed to be billing for the service. And again, these are CMS's rules. This is our list of what items are listed in the CPT book as being eligible work that is being done by the provider in looking at time and qualifying time. So you can see we have preparing the patient, obtaining a history, a medically appropriate exam, counseling, ordering meds. All of those are part of the time that a provider can, when properly documented, count toward the total time of the visit. Referrals, documentation in the record for clinical information, independent interpretation results. So all of these count in that time element for the visit. So it's just a matter of which is going to give you the highest level. For 2023, We can see that there were some minor changes as we look at our ED visits and making sure that we're doing critical care correctly. So the list of qualifying activities for time do not specify whether each activity is face-to-face or not. To my knowledge, CBT has not defined face-to-face and non-face-to-face, but we're going to assume it means just exactly what it says. And so as we look forward to providing different services, understanding that it is possible that the provider that spends the majority of the time may not be the provider that saw the patient or even performed any portion of a service, as we're looking at something like split shared. In 2023, the physician fee schedule said that the documentation had to identify who the two practitioners are that were performing visits. So that has not changed. Making sure that the information in the medical record shows the two is really they're important. If we look at claims identification, there has been in many years, I think I started working on a project for NPs and PAs probably over 20 years ago. There has not been any way to identify that this claim was performed as a split shared visit. And so they're like, well, we're making all these changes. Let's, make it a change that you have to append a modifier. So split shared billing, we append the modifier FS. If you don't append the modifier FS, then technically speaking, they would not be allowed to bring both sets of documentation together to find the level of service. And so that could be very costly from an auditor's perspective. This includes critical care. Anytime we're doing a split shared visit in critical care as well. So here is from National Government Services. It says, how will the substantive portion of a split or shared visit be defined in 2023? And it says, work performed by completing any of these elements. Please explain the differences between incident to and split shared. And it goes through and explains it a little bit differently. Not a little bit, it explains it in a way that hopefully will hit you differently as you're trying to understand. And then remember, we had a reference chart from National Government Services for our other Incident to services. For these, you can see, so here we have a hospital inpatient, its initial or subsequent care, our non-physician practitioner and MD split share the visit. What does the MD have to do? If we look at a subsequent hospital ER observation, gives us information. The MD in this point collaborates with the non-physician practitioner, but doesn't have to have a face-to-face. So different scenarios. This was reviewed in 2023, so at the end of last year, we've not seen anything new, but it certainly needs to be updated. For split shared visits, and again, this is where the PA and the physician are both seeing the patient. These are major changes in 2024. So when we look at CGS says in 2021, here's some rules. Their website needs to be updated, but it does give us valuable information on what they were thinking and how they might react. Tells us that sufficient medical record documentation is the proper key. We have to have medical necessity, and we have to have information on both providers, linking the note to the other note, if they're not, already physically linked, if you will, and then confirming who saw the patient face-to-face, who didn't. And then it says, here's some examples. I personally performed face-to-face with the patient. My findings are as follows: tried a warm compress. I did a exam of the area, incision and drainage not done, and signed. Pretty quick, to the point note. I personally performed a face-to-face diagnostic evaluation. I've reviewed and agree with the care plan. History and exam shows me abdomen was tender to the touch, but no rebound, etc. So just, tell the story of the patient and how they're seeing the patient. It then says, in addition to comply with CMS medical documentation standards, CGS would consider the following medical record documentation adequate. The following, so I have personally seen the patient, examined them independently, reviewed the history of the exam, and agree with the assessment and plan, but the following would not: patient seen or patient seen and signed. Now, as we're looking at the amount of time that's spent, this allows for enough medical record by the physician to support a split-shared visit, but now we have to look at how much time did that take and who did the substantive portion of the work. So a physician can use a note like this, but understand in using a note like this, you're not showing the amount of work that you did, and therefore billing it under the physician in this instance, to me, is problematic. For critical care services, we want to be sure that we make note of technical corrections that came in. Back in 2022, there was a final rule, and there was a comment made in error about the amount of time that was the minimum standard for a critical care visit, and when that time standard changed over to an allowance of adding on the subsequent 30 minutes. In making that correction, it began discussions, and I would say in my world it was about 50-50 for who had known CMS's position on critical care. So what we're talking about is this. The code reads, the first critical care code starts at 30 minutes and goes to 74. The next code reads 75 to 104. The question is, if you get into the 75th minute, is that good enough to bill that add-on code? CPT talks about a block of time, meaning you get to 75 minutes, you're going to bill for the next block of time, which would be another code 99292. But CMS says, no, 1 minute into it, you're not meeting the requirement of a code that has 30 minutes in it. And therefore, we're not going to pay for that. CMS specifically says you have to go all the way through the 30 minutes. And at the end of the 30 minutes, the additional 30 minutes, then you can build the add-on code. And that's significant. That's something where we have to work with our staffs and with our providers to relay appropriate information so that they can bill based on carrier rules. Now, if the physicians, providers are in the same group, they can certainly aggregate their time to meet that billing requirement. And that's true of post questions as well. So the physician fee schedule final rule for 2024 says for critical care visits, the substantive portion means more than half the total time spent by the physician or non-physician practitioner performing the visit. Pretty straightforward on the time element there. But the billing challenge we have with critical care is we have two different references of when do we use that second code. So for example, if we look at a patient, remember I used it 75 minutes, that's 1 minute into the next block of time. This is from our CPT book. It says you're 1 minute into the block of time, you can bill the code. Whereas CMS says, no, you can't. You have to be fully through that 30 minutes, all the way up to 104 minutes before you can bill that code. So what happens is the information has to be given to your billers in order for them to apply the rules. Because as you can see, there is a whole code difference potentially, depending on where the time element falls. In other words, you couldn't bill a 99292 at 75 minutes for Medicare, but you can bill for those that don't follow Medicare, that follow CPT. You could bill that with an add-on code. So it's a matter, again, of understanding the rules. So we talked about incident 2. We talked about the supervising physician. And we talked about reflecting that information on a claim. Put this information in. These initials, these alpha characters that are called qualifiers are going to go, now when I tell you the left of the dotted vertical line in item 17, I don't expect you to know where that is. So that's where I'm going to come over here and show you. So it says name of referring provider. And so if we have an incident to service, we have to, as we said, identify who is the supervising physician of that service. And it may not be the provider that's in the office that day. So making sure we get all the information in box 17, in box, what is that, 24J, and then down here in the final box. This information comes out of the Medicare Claims Processing Manual, Chapter 26. You can look it up if I'm confusing you with my comments. But at the end of the day, what you're trying to do is to reflect all of the providers that are involved in this visit, in the care of this patient. So that's the supervising entity, the physician that's in the office, and then there is the physician who is working with the PA on this patient. So they could be the same, they might be different. You just have to reflect them on the claim form. So again, this information is in the Claims Processing Manual. Now, the last thing I want to talk about just very briefly is Blue Cross Blue Shield of Michigan, just as an example of how different a payer can look at the rules when it comes to incident to, or as they call it, indirect billing. According to Blue Cross Blue Shield, we're going to use the indirect method, which is incident to, if any of the following criteria are met. Now, it doesn't give any location, place of service, type of service. It just says if you meet this requirement, so any service where the physician delivers any specific component of the service. So in that instance, it could be a split shared visit where the physician and the PA are in the room together, or at different times, to kind of tag teaming on the visit. Blue Cross Blue Shield says you can bill that indirectly under the provider's number. Services which the physician has provided specific clinical direction to the non-physician practitioner. Well, that was a little easier, look at the schedule, see this, patient that has 5 chronic illnesses coming in, want to make sure, we're going to give them good information. What are we going to do for that patient? And then the last one, services for which the PA or CNP has presented pertinent clinical findings and obtained approval of the service prior to the end of day following the service. This allows much more latitude for the provider. The provider doesn't have to be in the office. The provider can be anywhere as long as they have a conversation or interact with the PA by the close of business the following day regarding their patients. When we look at what they say about the documentation of this discussion, it says it doesn't have to be lengthy or detailed. It's not necessary for the physician to document their involvement. And in this record from 10, 15 years ago, it says documentation by the PA, such as I spoke with Dr. Smith and got approval of this plan of care, is appropriate. So that just gives you an example of how different the rules can be for your payers when it comes to incident to billing. How different it can be for what they call direct and indirect billing. I hope this has been helpful to you as you sort of work your way through the quagmire of, we've always done it this way, but we're not sure we're doing it right. And I think that's the biggest question, biggest thing that I see when it comes to be on this topic is, we've always done it this way, but I look at the rules and I'm not sure I'm doing them right. So with that, I'm going to ask Richard to come in and see if we have any questions so that we can get your questions answered, so we can get you doing things right if in fact you are doing them a little sideways or a little bit wrong. So Richard, can you come back in and help?
Thank you, Jill. Ladies and gentlemen, we would like to remind you that if you wish to ask any question, kindly type them in a question box now. And Jill, I think we have some questions, so I'll just bring up to you.
Okay.
My doctor used their PA and NP in the hospital doing post-operative visit and discharge. Is that okay?
Okay. So if you're not going to bill for the service, there isn't a problem. So if they're post-operative visits within the global, yes, that's certainly fine. Discharges, again, if the discharge is in the global, that is okay to bill because again, you are not generating a charge. But if for some reason you were consulted on the patient and you're asking, can the PA bill a discharge summary incident to, we're in the facility setting, so no, it would have to be a split shared visit, which would mean that the physician provider would have to have seen the patient in order to perform a substantive portion of the visit if they wanted to bill it under them. Otherwise, you would need to bill it under the PA. I hope that answers your question. Thank you, Richard.
Thank you. The next one is, you said there must be a plan of care in place. Can you explain this a bit more?
A plan of care is, in general, something that is general protocols. In other words, remember, it's an incidental, though integral service. And so, watch the patient's hypertension. If their blood pressure goes out of the bounds of these numbers, I want to see the patient. I want to have a discussion. Or follow the patient for their glaucoma, follow the patient for their whatever. Remembering the minute that there's a change in their condition, that's out of the bounds of incident 2. And then we have to look at what we're doing. So that plan of care says, what is it that this patient can come back in and see the PA for and have it be billed under the physician? If it's not in the plan of care, then you're out of the bounds of incident 2, and it would have to be billed directly by the PA. Hope that answers your question.
Thank you. We have another one is, we are in ortho office. The doctor goes in after the NPP and taking the patient's history, done an exam, and has discussed the case with them. We are billing these under the physician. Is this okay?
Depends on their insurance. For someone following Medicare rules, that is not okay. Medicare doesn't allow split shared visits in the office. Now, if you're a facility, then it would be okay if you're billing for Medicare. A facility office is where you're a member of an outpatient department of the hospital. It's where your patients get 2 bills, one from the doctors, one for the facility fee. But if it's traditional Medicare, that would not be okay. If you have an insurance like Blue Cross Blue Shield of Michigan, where there is that interaction between the two, that would be allowed. So the answer to your question is yes, no, maybe, depending on the insurance of the patient and the denotation of your office location. I hope that answers your question. Thank you, Richard.
Thank you. These were all the questions for today, Jill. I would like to turn the program back to you for any of your closing remark, and then we can conclude the session.
Okay. I can tell you that non-physician practitioner services, which includes NPs, PAs, certified nurse midwives, nurse specialists, are being looked at by the insurances. And a lot of it is because, in my opinion, for a very long time, the billing has not been done properly. In my state, it's particularly difficult because we have Blue Cross Blue Shield of Michigan rules that are very, very different than Medicare rules. And so following one set of rules for everybody is going to get you in trouble, so to speak, because the rules are different with those 2 major carriers. So you need to know in your state, number 1, what can your PA do? Number 2, for your major carriers, what are their positions on the credentialing of your PA, and then on their scope of practice and what they are and aren't allowed to do. And then lastly, what's their position on incident 2 or direct or indirect billing, depending on what the carrier calls it. So that's all I have to say. Richard, thank you so much, everybody. Again, sorry for the coffee.
Thank you, Jill, for this amazing webinar. Ladies and gentlemen, this is a conclusion for today's webinar titled Coding and Billing Update for Physician Assistant Services. To disconnect, you can simply hang up. Thank you.